Good evening, everyone, and welcome to today's webcast, Nail Psoriasis. My name is Corinne Pettit, and I will be your moderator for tonight's presentation. Before we get started, I'd like to go over a few items so that you know how to participate in today's event. We've taken a screenshot of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You've joined the presentation listening using your computer speaker system by default. This means if you can hear music through your computer, you should be able to hear the presentation. If you prefer to join over the telephone, just select Use Telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenter by typing into the questions pane of the control panel. You may send in your questions at any time during the presentation and we will collect these and address as many as possible at the end. Before I introduce today's speaker, I'd like to take a moment to tell those of you who may be new to the Foundation about who we are, our mission, and what we do. The National Psoriasis Foundation is the world's largest nonprofit patient advocacy organization dedicated to psoriasis and psoriatic arthritis, and we serve as the voice for millions of Americans who are affected by these diseases. Our mission is to drive efforts to cure psoriatic disease and improve the lives of those affected. In order to move our mission forward, we engage thousands of volunteers around the country in activities that will lead to a cure. For more information about these opportunities, you can log on to our website after today's program at www.psoriasis.org. One of the ways we drive our missions forward is through our Patient Navigation Center. Our team of patient navigators can help you find specialists, access new medications, and connect you to others in your community who are living with psoriatic disease. I'm excited to announce that the Patient Navigation Center has a special resource for today's webcast participants. After the webcast, you'll be directed to a post-event survey with an option to be contacted by an NPS patient navigator. All webcast attendees who choose to work with a patient navigator will receive a complimentary journal and a pen to set to working towards their psoriatic disease health goals. Keeping a journal is a great way to track flares, record symptoms, and reflect on stressful situations. You can also use it to write down questions for your doctor and take notes during your appointment. Remember, to get started, just check yes, I would like to be contacted by a patient navigator on your post-event survey. Finally, I would like to thank our sponsors, AbbVie, Celgene, and Novartis for making tonight's presentation possible. Now I'd like to introduce our speaker, Dr. Ronald Presick. Dr. Presick is the medical director of the Washington Dermatology Center in Rockville and Frederick, Maryland. He is a board-certified dermatologist and completed his fellowship in dermatological immunology at the National Institute of Health. Additionally, Dr. Presick is an assistant clinical professor of dermatology at George Washington University School of Medicine, where he is involved in teaching dermatology residents. He has been consistently voted as one of the top doctors by the Washington Magazine and repeatedly been named one of America's top physicians by the Consumer Research Council. He has written many scientific publications and frequently speaks at medical conferences around the country and internationally. Dr. Presick is a member of the American Academy of Dermatology and a member of our medical board here at the National Psoriasis Foundation, which provides guidance and leadership on behalf of the Foundation for medical issues related to the psoriasis and psoriatic arthritis community. We're honored to have you present for us tonight. Welcome, Dr. Presick.
Well, thank you very much. I'm so happy to be here and a part of this program and really enjoying being on the medical board for the NPF and seeing all the great things that we've been able to do over the years and continue to do hopefully over time. I'm really looking forward to going through this topic with you. I know people have a lot of questions about their nails, and I think that this particular program will be very informative, and I look forward to answering your questions at the end of it. So let's get started and see if we can advance the slides. There we go. Okay, we got it. So this is what we're going to talk about today. We're going to talk about the different types of conditions that you can actually see with nail psoriasis. So not everyone looks the same when they have nail psoriasis. There's multiple different ways it can show up visually. And so we'll talk about the reasoning for that and the different treatments for that. And we'll also talk about the correlation between nail psoriasis and psoriatic arthritis and go through the medical treatment options, and then identify additional educational materials and resources you can use to get more information. Now, about 50% or more of people with psoriasis can get nail psoriasis, and about 80% or more, if they have psoriatic arthritis, can get nail psoriasis. And fingernail psoriasis is more problematic than toenail disease just because it's visible, and also a lot of people have trouble using their hands when they have fingernail psoriasis, because that's the reason why you have nails. They help you with the functioning of your hands. And if they don't work well, then people end up with problems. So patients who have this problem report embarrassment and pain associated with their nail psoriasis. And fingernail psoriasis can be an early sign of psoriatic arthritis. As a matter of fact, to diagnose psoriatic arthritis, they use something called the Caspar criteria, where there are 5 different things that rheumatologists and dermatologists look at to make the diagnosis, and you need to have 3 out of the 5 criteria. One of the criteria is nail psoriasis. That's how important nail psoriasis is to diagnosing psoriatic arthritis. So 80 to 90% of people with psoriatic arthritis actually have nail disease. So let's just look at the nail for those of you who aren't familiar with the anatomy, so it'll be easier to understand what's going on. So I'm showing with my pointer here, this is the nail plate that everyone sees as part of their nail, and the nail plate is formed from cells that are right here called the matrix. And the visual part of the matrix is called the lunula. It looks like a half moon and it's white, and you see it very clearly on your thumb. And those cells actually produce your nail plate. And then there's the cuticle here, which protects the nail plate. It's like a water seal. So it's a little piece of skin that hangs over and attaches to the nail itself, so water can't get underneath it. So it's very important to have a cuticle. And what you can see here on this side, this is looking at the finger kind of from a lateral point of view. So what you can see, this is the bone of your finger, and then this is the skin that grows over with the cuticle, and then this is your nail plate. And what this part right under the nail plate are the cells I just talked to you about, which is the nail matrix, which actually produces the nail plate. Right in front of that is called the nail bed. So in psoriatic nail, it depends where the inflammation is. So if your psoriasis affects this part right here, the nail matrix, you get problems with your nail plate so that the nail can get nail pits or crumbling nails. And if the psoriasis inflammation goes into your nail bed, then you get other problems with your nails, such as onycholysis, which means your nail starts lifting off the nail bed, where you get thickening and scaling called hyperkeratosis, which is caused from the psoriasis immune cells being in the nail bed. So what you see on your finger will be based upon where the inflammation of your psoriasis is. Now, there are tendons that go across the finger and attach actually to the side of your finger, and those tendons actually are part of the psoriatic arthritis. So when you get psoriatic arthritis, commonly it'll involve the tendons on the side of the finger. Now those tendons can attach to the actual nail matrix right here, and that's the reason why so many people with psoriatic arthritis actually get problems with their nails, because the tendons can affect the nail matrix. So that's a little anatomy class for you. And these are some pictures of what we see in nail psoriasis. So this is the typical nail pits that you would see in psoriasis, and that's because the immune cells of psoriasis are affecting this part up here called the lunula or the matrix. So the matrix has inflammation. In this one here where people get discoloration or oil drops, there's inflammation is actually in the nail bed itself. And then when the nail becomes crumbling, it means that there's even more severe damage to the matrix than there is with pitting, and that's why the nails are more severely affected. Other things you can see are loosening of the nails, and that's because there's inflammation in the nail bed. So what happens is the nails start to lift off the nail bed, and you get this whitish area called onycholysis. And when people have this, they have to be very careful to keep their nails very short and also to prevent water from getting under their nails. So we recommend using a blow dryer after you wash your hands and gloves when you're doing wet work. Because when you get water under your nail, then a fungus can appear. You can get a candida yeast infection, or you can get another kind of infection that gives you like a ringworm or an athlete's foot fungus called a dermatophyte. So in this nail here, you get thickening and hyperkeratosis because the psoriasis involves the nail bed itself. Now this kind of thick nail looks just like a fungus. So doctors have to clip a bit of the nail and send it to the lab to get a culture to see if it's just psoriasis or if it's just a fungus. We can't tell by looking. So in a case like this, we would have to take a culture. If you just have nail pits, you don't need a culture because it doesn't look at all like fungus. But when it looks like this, we have to take a culture because if it's a fungus, we have to treat it with antifungal medicines, either topically or pills. We can't use psoriasis medicines if it's a fungus. So that's why we have to take a culture. When we do studies in psoriasis of the skin, we do something called PASI scores, which are published, which is psoriasis area and severity index. But when we do studies on nails, we do a nail severity index, where we split the nail into quarters and then we give it up to 2 points if there's an involvement of either the matrix or the nail bed. And so this is just so that you can see how we actually quantitate. So when we do treatments over time, we try to see if the treatment actually will improve the nail severity index over time. And that's how we do studies. Now, what's different about nail studies versus skin studies is when we treat the skin can clear up usually in many cases in 4 weeks or 8 weeks. But in nails, it takes longer because if you have pits in your nails, the pits won't go away even with good treatment. The nail has to grow out, and then the new nail that comes in won't have pits anymore. So it can take a while to see results. So for example, in a fingernail that grows 3 to 4 millimeters a month, it can take 6 months for a fingernail to grow from one end to the other. So often when we do studies, we don't see much improvement for the first 3 months when we do studies, which could be different from the skin. Now, when we do toenails, it can take even longer because for an adult, it can take 18 months for a toenail to grow from one end to another. So it can take a very long time for us to see results. And so that's the important thing you have to know. And also, like I told you, we need to take a fungal culture test in a lot of cases where there's a lot of thickening and scaling under the nail to make sure there isn't a fungus infection. And the people who are most prone to that are the ones where the nail lifts off the nail bed and water gets underneath your nail. So I'm going to talk a little bit about a paper that was published in the JAMA Dermatology in 2015. And this paper actually was a questionnaire done from all the board members who are psoriasis experts on how to treat nail psoriasis, and we gave our opinion based on several scenarios. So they gave us a scenario, and we told the person who was writing the article how we would treat it, and they pooled all the results and they published it. The only thing about this paper that I'm going to show you is that we didn't have a couple of the newer drugs that are currently used to treat psoriasis and nail psoriasis. If people are taking Taltz or Cosentyx, those drugs were not included in this paper. So we just have to just let you know that that we kind of added that in afterwards. So that's not part of the original paper. So I'll show you what we did. So for example, one of the questions was to the medical board, if you have a patient who has 3 to 10 fingernails affected, but no skin problems at all, and the patient said they had embarrassment and mild pain, how would you treat it? So the board members sent back their responses, and this was how they responded. They responded they would use a high potency topical steroid to the nail itself. Now normally when we put it on this, we have to make sure we rub it on the cuticle area and over the white lunula area, where right at the proximal part of the nail, and that's because that's where the inflammation of the matrix is. So the topical steroid works best for that. We can use vitamin D. It comes as a solution or a foam. We can use intralesional steroid injections, but injecting into the nail is very painful because there's so many nerves around the nail that this is not a very pleasant experience for people to do. So we have to sometimes numb the nail with a topical numbing agent for 30 minutes before we do it, or we use some anesthesia like you would going to a dentist and get a little shot at the side of your finger to make it numb before we do that. Another treatment that has been recently published is using something called tazarotene gel. This gel is a prescription for acne, but it also is prescription for psoriasis. And this wasn't in the paper, but it's also known to help psoriasis, especially if you have pitting or onycholysis. So that's where we would use these treatments. The next scenario was they asked the board members, if a patient came to you and had 5 to 10 fingernails affected, no skin symptoms, they did not respond to any of the topical treatments we just talked about, they had embarrassment and moderate to severe pain from their fingernails, what would you treat them with? So the responses were the following. The number one response was adalimumab, and that's partly because the FDA gave an approval to treat nail psoriasis with adalimumab, and perhaps the board members felt that that was probably the most likely one to work for most of their patients. So they picked that number one. The other ones they picked were etanercept, intralesional corticosteroids, which we just talked about, ustekinumab, methotrexate, and acitretin. So adalimumab was their favorite, acitretin was their least favorite for a scenario of a patient that we just discussed. The next scenario was someone with 5 to 10 fingernails affected, but this time they had skin involvement. And we consider it moderate skin involvement because they had 8% of their body covered with plaques of psoriasis. So if you have one palm of psoriasis on your body, that's considered 1% BSA. So we were looking at a theoretical patient who had at least 8 palms worth of psoriasis on their body, along with 5 to 10 fingernails involved, with embarrassment and pain from their fingernails. So they asked us what we would use. So the recommended treatments with the highest enthusiasm was adalimumab, etanercept, and ustekinumab. And also recommended was, but less favorable, were methotrexate, acitretin, infliximab, and apremilast. I added to this list the secukinumab and ixekinumab, which are the IL-17 blockers that were not involved in this study, as I told you, because they weren't approved yet. But since that time, we've had some papers that are showing that these work. So if any of the listeners out there are on any of these newer IL-17 blockers, we do have data to show that they can help your nails, okay? The next scenario was for people who had not only 5 to 10 fingernails involved, with skin involvement at least 8% body surface area, but they also had the joint arthritis, so psoriatic arthritis. What would we use? So the number one response again was the adalimumab, and the other responses were etanercept, ustekinumab, infliximab, methotrexate, apremilast, and another drug that is not approved for psoriasis but approved for psoriatic arthritis called golimumab. And I also added the islukinumab and secukinumab. Those are the IL-17 drugs that were not involved in this paper, but we know that they work for both the skin and the joints as well. So that's why I added them to the list. So these are how the board members responded, and this was published in JAMA Dermatology in 2015. There are some alternative treatments that we use for people that have tried these things that we talked about that didn't work, or for some reason, if they can't tolerate some of the medicines that were on the list, whether they get side effects or whether they have contraindications to the medicines, we can try alternative treatments. What alternative treatment really means is we don't have the very strong studies and data that we have in regular treatments, but they're called alternative because we have some case reports or some theoretical reason why we think it may help, so we try it. So that's what alternative means. So for example, you can use a laser called an excimer laser, which emits narrowband UVB, which is called phototherapy, but not in a big light box, but through a laser beam. And we can shine it right on the nail itself, especially in the matrix area, which produces the cells, which has the inflammation that causes the nail plate to become problematic. So it works best if you have a nail matrix problem. So we can try that. Another one that has been tried is called a pulse dye laser. That's a laser that's actually used to treat people who have red birthmarks on their skin, like on their face, or red blood vessels on their face. That's what we really use the pulse dye laser for. But since people with psoriasis often have enlarged blood vessels in their skin, in their plaques of their psoriasis, people have used the pulse dye laser to treat their plaques on their skin or in their nails with some success. And there's some case reports about it, but no big studies. There's also another couple of papers done from a Chinese group using indigo naturalis oil extract drops that are applied to the nail itself. They also have papers using it on plaques of psoriasis on the skin or on the scalp, and shows that it's equally effective, or in some cases even more effective than using vitamin D in nail psoriasis. So those are some things. And the indigo you can actually buy online. You don't have to have a prescription for that. So there's a few things that I wanted people with psoriasis of the nails to know what you should do and what you shouldn't do. Number one is that try to keep the nails short, because if the nails are long, especially if your nail is lifting off the nail bed, if they're long, when you go to grab something, you can bang the nail and lift it even more. And that causes a problem, because when you wash your hands, water will get underneath the nail and a fungus can appear. So it's very important to keep the nails short. If you have very thick nails, especially toenails, and you can't cut them very well, it's good to soak them for 10 or 15 minutes before you do that, and that might help you cut it. The only problem is when you soak your nails, water can get underneath them and you can get an infection, a fungus infection especially. So I always recommend to my patients to take a blow dryer for 10 or 15 seconds on cool air and put it on the nail after they soak it, or after they take a shower, or after they go swimming, because that prevents the water from going under the nail and causing an infection. If you have a job that requires you to use hand tools or type a lot, anything that'll cause trauma to the nail itself, that makes more psoriatic nail to appear, because just like with your skin, if you scratch your skin and wound it, the immune cells come into the scratch and the wound and can trigger psoriasis to appear. Well, the same thing happens with the nails. That's why if you're prone to nail problems, you need to wear gloves to try to minimize the amount of trauma and friction to the nail itself to try to help them heal. Because as you know, when you have psoriasis on the skin, if you scratch it and wound it, the psoriasis gets worse. Another thing to be aware of is that when your nails have psoriasis, just like when your skin has psoriasis, it's good to moisturize your skin. And so it's important to also put moisturizer on your nails as well. Some things that you don't want to do is, remember I showed you when we looked at the anatomy of the nail, there's a cuticle, which is a piece of skin that kind of goes over onto the nail plate from your skin, and that protects the nail from getting water underneath. It's like a water seal. So you don't want people to push back your cuticles, or you shouldn't push it back yourself, because if you remove the cuticle, then there's no water seal anymore, and water can get under your nail and get infected. So don't push your cuticles. Also, when people have thick skin under their nails, they like to take nail files and other things and put it under the nail to try to remove it. And that's very bad, because that causes injury to the nail bed, and that causes more immune cells to come into your skin to make the psoriasis worse. Plus, if you push things underneath it, you can lift your nail up more off the nail bed, and that causes more infection, because water can get underneath there and it can get infected from bacteria or fungus. Other things that you should avoid doing, when you use nail polish remover, avoid acetone. So buy acetone-free nail polish removers. Also, another thing you can do is when you buy nail polish, try to get formaldehyde-free nail polish, because a lot of people get allergies to formaldehyde, and that can lift your nail off your nail bed, and you don't want that when you have psoriasis. So that's important to avoid that as well. And those are all the little tricks that are helpful when you're buying nail polish. Just look for formaldehyde-free nail polish, and I think that should help. Also, if you're going to put glue on your nail, that's a little bit risky too, because if you're putting fake nails on with glue, some people develop allergies to the glue itself, and that can cause the nail to lift off the nail bed, and also cause inflammation and immune cells to come into your skin and your nails, which you don't want when you have psoriasis. So those are all the little tips I wanted you to know about. So just to end, I just wanted to go through some resources you can use to get more information about psoriasis and psoriatic nail problems. Through the National Psoriasis Foundation, you can look up psoriasis.org, or through the Navigation Center you can actually call and get information about doctors who treat psoriasis and psoriatic arthritis, get information about medication or insurance coverage questions you may have. Also, the American Academy of Dermatology website is also a very useful website for people who need more information about skin diseases or nail diseases. And So right now, that's the end of this webinar, and I'll be taking some questions. Thank you.
Great, thank you so much. So we will move into our question and answer time, and we have some great questions here. Our first one, I understand that taking biotin supplement daily could be positive for one's nails. If true, what dosage should one take?
Biotin is very helpful for people who have brittle nails or nails that crack very easily. So the studies that were published showed that people took 2.5 milligrams a day. And it takes at least 3 months to see an improvement. So this is something you can buy over the counter. You don't need a prescription. And it does usually work very well for people who have brittle nails.
Great, thank you. Next question here. What do you do if you have itching under the nail and at the nail borders?
Itching is usually caused because your psoriasis immune cells are in your nail bed and around your nail, and that is the reason why. So our job is to get the immune cells out of that area and go back in the bloodstream, and that helps your itching go away. So you can use some of the topical treatments that were recommended in this webinar, especially topical steroids. Under occlusion would be useful, or sometimes the intralesional corticosteroids would be helpful for people. If they do go on any of the biologics that are listed because they have more severe cases or they have skin or joint involvement, that should take care of the itching as well.
Thank you. Next question here. Can you please clarify pitting in the context of overall psoriasis and psoriatic arthritis? Is it a precursor or a symptom?
Pitting is actually part of the actual disease itself, because you can't get pitting unless you have inflammation in the nail matrix. So when you have inflammation from psoriasis in the matrix, which are the cells that produce your nail, you get pitting. So pitting is a result of having psoriasis in the nail matrix.
Great. Next question here. If the nails are damaged beyond repair, would you recommend having the nails removed?
Well, usually if they're damaged beyond repair, we would normally treat the psoriasis with any of the treatments we talked about, whether you use topical therapies or phototherapy or biologics, and then you wait 3 months and the new nail will replace it, the bad nail, with a very healthy nail. So that is the goal of our treatment. It doesn't matter how bad your nail is, our treatment should work to give you a new nail. And that's the goal of the treatment. So most of the time we can actually make people's nails better with the treatments that we discussed. So you don't have to remove them. You can just go on treatment and watch the new nails come in.
Great, thank you. Next question here. What kind of day-to-day moisturizers can we use on the nails?
Well, some people like to use special moisturizers that are made for nails, like something called Cutamol, which you can get over the counter through the internet or through your doctor's office. Other people just like to use Vaseline. Other people like to use their favorite moisturizer that they put on their skin. They just put that on the nails as well, and that should work just fine. Just when a lot of people put moisturizer on their hands, they just kind of don't put it on the nails. They forget to do it on the nails. And so even if you just put a moisturizer on your hands after you wash your hands, just put it on your nails as well, just your favorite moisturizer. One that works well for your skin should work for your nails. Some doctors prescribe a special urea cream, which is a little bit more hydrating. So if you can't get results with the over-the-counter, you can get a prescription version through your dermatologist.
Thank you. Next question here. Sorry about that. Does temperature affect nail psoriasis? I've noticed that my nails are worse during the warmer months and better during the winter months.
The nails don't typically vary from season to season that much for most people. So the answer would be that's not the common scenario. Some people find their psoriasis is worse in the winter just because their skin gets drier and they get little cracks in their skin and the psoriasis can appear from the dryness. But Usually it's not weather related. Sometimes people do more physical activities. They do more gardening and other things in the summer months, and that'll damage their nails so that their nails will be worse in the summer just because of the activities they're doing.
Great. Next question here. If I'm doing phototherapy on my hands, do my nails need to be protected during treatment?
Usually we don't protect them. There's no danger in having phototherapy to your nails. As I discussed in the webinar, we actually use phototherapy through the laser to treat the nails. So there's no harm in getting your nails treated during phototherapy.
Great, thank you. Next question here. Any truth to Vicks Vapor Rub helping clear nails?
We don't have any studies with Vicks VapoRub in psoriasis, so the answer would be it's not known. I don't know. On the internet, there's a lot of people that claim that Vicks kills fungus when they have fungal nails, but there's no data to prove that, so I don't know.
Thank you. Next one here. What can be done if a nail is split down the center?
Well, it depends what the cause of the split is. That's usually not a common presentation for psoriasis of the nail. So you'd have to get your dermatologist to look at it. You may have had an injury to the nail matrix and those cells died, so that's why there's a split in the nail, because the cells that should produce the area that's split aren't producing a new nail anymore. But you need to have your dermatologist take a look at that.
Thank you. Next one here. If a person has psoriasis on their fingers, are they likely to get nail psoriasis?
You're more likely to get nail psoriasis if it's on the finger, because if you have immune cells that are in the skin around your nails, it's likely to affect the nail beds and the nail matrix. So the answer is yes.
Thank you. Can your nails get back to being normal after they've been affected?
Yes, many of our treatments that we use could make the nails perfectly normal again.
Thank you. Next one here. My nail psoriasis seems to show up when using Dovanex. Has this relationship been confirmed?
You're saying that the nail, psoriasis nail shows up when using Dovanex? No, that hasn't been confirmed. They've had some studies using Dovanex or vitamin D calcipotriol to treat the nail psoriasis, but there isn't any data showing that Dovanex causes nail psoriasis.
All right, thank you. We have a couple questions here asking if it's safe to get a pedicure.
Yes, it's safe to get a pedicure. It's just that if they soak your feet, I would recommend that you take a blow dryer afterwards to make sure a fungus doesn't get under the nails. Probably, since people with psoriasis of the hands and feet involving the nails are more likely to get an infection because the nails lift off the nail bed, it's good to keep them dry and also even bring your own equipment to make sure you don't get an infection.
Thank you. And a question here, what causes lines in the nails?
There's different causes for lines in the nails. Sometimes it depends. If you get a horizontal line, it's called a Bose line. That sometimes appears because you have a health issue. You were on medication or you were very sick, so your cells stop producing the nail for a short period of time while you're sick. So it grows out as a horizontal line. You can get vertical lines for various reasons. You can get it from vitamin deficiencies, from thyroid conditions. There are different causes for lines. You can even get the vertical lines from just aging skin as well. And as you get older, your nails can develop vertical lines. So there's many different causes for that.
Thank you. And one last question here. Does the state of your nails reflect how well your DMARDs are working for your psoriatic arthritis?
Usually it does, because if you can get inflammation away from the tendons that are close to the nail matrix, if the nails are growing out well, chances are the inflammation in your psoriatic arthritis should improve as well. So it's usually a good sign.
Great, thank you so much. Well, thank you, Dr. Presick, for sharing your expertise with us. And if you have other questions, please contact our Patient Navigation Center by phone, email, live chat, or Skype. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. As a reminder, if you indicate that you would like to be contacted by a navigator in the survey, you will receive a free gift. And thank you again to our sponsors, AbbVie, Celgene, and Novartis. Finally, I just want to mention that a recording of tonight's webcast will be available shortly on our website, and you can access our complete webcast archive by visiting psoriasis.org/webcast. Thank you, everyone, for joining us tonight, and I hope you have a lovely evening.